This week on the BackTable podcast.
It's a learning curve. Getting, the first 30, 40 cases under your belt is very important before you start to get a little bit more comfortable. I think that even after that, though, it's a humbling procedure sometimes. You feel like, oh, I'm getting the hang of this now. And then next day you're like, well, I feel like I've never done this before. So it's, I think, patience, having the, knowing that there are other options if you can't do the procedure as well. Like you're not abandoning the patient if you don't try for, 4 hours to try to do a prostate embolization. I'll have half my staff quit, but if I take that long.
I'm your host, Dr. Baheti. I'm an interventional radiologist out in Tacoma, Washington. I get to talk with a colleague on the other side of the country today, Dr. Andy Vartanian. He's an independent interventional radiologist and the medical director of PrecisionIR. Andy, thanks so much for coming on the show.
Thank you for inviting me. Honored to be here.
Well, you have a pretty interesting career path and history, so let's kind of get into that. Tell me a little bit about your training and kind of what got you to the job you're at right now.
Sure, absolutely. So I grew up in Southeast Michigan, so I haven't moved very far in my life, but went to medical school at Wayne State in Detroit and trained at Beaumont Hospital in Royal Oak, Michigan, which is now Corewell Health, and was in the sort of academic setting for about 15 years. Then I came over to PrecisionIR in 2022.
How big is that group? Is it just you?
So right now I have one other partner that works about 20% of the time. It's mostly just me here in the office, but he helps cover some time off and things like that. But
oh, cool. Okay. And he's an IR doctor too?
Yep. Yeah, he was one of my mentors actually at Beaumont, and one of the first people to do Y90 in the state of Michigan with Riyadh Salem. And,
wow. Yeah.
Yeah.
Okay.
So our original plan when we came over to the office was actually to develop Y90 in the OBL. And we've done quite a few radioembolization procedures here in our office. But, as things just sort of evolve, you don't really know which way things are going. PAE has really become the predominant part of our practice.
Isn't that interesting? I bet you never thought you'd be doing prostate embolizations kind of when you left your career 15 years ago.
I did not. I absolutely did not. And, it was interesting. I'm glad I did a couple when I was in the hospital before I came over to the office because, I view prostate artery embolization probably as one of the most challenging procedures that we do as interventional radiologists. And the learning curve is extremely steep, but it's a fun procedure and it's very rewarding.
Tell me a little bit about kind of the factors that made you leave your academic practice.
So that's a great question. I really, really enjoyed all the people that I worked with at Beaumont, and every day though was just like you're trying to pass the next test, trying to do the next thing. You're in residency, trying to get into the fellowship you want. Then you get into the, the job you want as a staff, and I felt like almost kind of a weird way to say it, but just where do I go from here once I became an attending? And it's just like, are you going to the coal mine every day? And it just obviously not, but I mean, it just wanted something different, wanted to do a little bit more. When I was in my 30s, taking call was very, very exciting. Once I got into my 40s, it became a little bit less exciting. And now that I'm in my mid 40s, any call after 10 o'clock at night is recipe for disaster the next day.
I mean, I'm not that old, but I feel like even at now compared to where I was as a resident, disruptions in sleep just get me way worse for the next day.
Absolutely.
There was an interesting thread on Twitter recently of one of the vascular surgeons who, if he gets called in overnight to do a case, he talks to his patients the next day and he gives them an option. Do you want to reschedule your case with me? I've been up all night, or do you want to just go through with it? And he said 100% of the time they just want to reschedule because they want us rested and they want us at our best, Yeah.
100%. Yeah, it's amazing because as a resident and as a fellow, we're protected by all our work hour restrictions and everything like that. And, it's your staff, there's cases on the board, you got to get them done. And I think that was part of the reason that wanted me to leave the hospital setting. I find that hospitals just want to get bigger and bigger and bigger. And I feel like sometimes when that happens, we lose sight of our ultimate mission, which is caring for patients. And I feel that in the office setting, the attention that we could put to our patients is just unparalleled. We can't do that in a hospital setting. I mean, you go to a hospital, and in most of these hospitals, it's like you're going to a sports stadium. You park in a parking structure, you register in one building, and then you have to take a subway to the procedure room, basically. But
Yeah.
it's, here I have valet parking at our office, and, the patients very close to the door. There's no, some of our patients are elderly, a little bit more frail, and all that moving around. So we can just really focus on them here in the outpatient setting. And I really enjoy that.
Awesome. I think the reasons that I left pretty traditional private practice mirror a lot of the reasons you left academics. So I feel like maybe we're kindred spirits. I'm excited to talk.
Absolutely.
Okay. So I want to help the audience understand kind of your expertise in prostate embolization. Just give me a little bit of background about how many you do maybe in a week, or, how long you've been doing them for.
Yeah, absolutely. So, the first prostate embolizations I did probably were back in 2020, 2021, and didn't really ever do them with any frequency until, actually, to be perfectly honest, last year. And in Southeast Michigan, there's two big urology groups, and one of the groups is affiliated with IR centers. So there's an IR center shop in Troy, Michigan, which is about probably 10 miles from my office. And then there's another big urology group that I've, sort of partnered up with, and just really, they expressed interest about wanting to offer PAE for their patients. And we're part of the same organization, Michigan Healthcare Professionals. So it's a group of about 500 docs, multidisciplinary oncologists, surgeons, primary care cardiology, radiology. And they really expressed a lot of interest in wanting to offer this treatment for their patients. And we started doing it. And it was a little bit, slow to start, probably a handful of cases a month. But now it's, now I'm doing probably 15 PAEs a week now.
Wow, that's quite a lot. Yeah.
Yeah. It's really kind of just overnight, sort of. It seemed like it kind of exploded, which is very cool, I guess, for the business. But and it's also really cool to help all these patients.
So I think we always talk about the financial incentives, right, with OBLs and especially with PAE. I think since the development of IR centers, do you have a MSO model with them, or like how is the relationship between you and this urology center?
So we are, as I said, part of the same organization. So we're technically employees of the same organization. We bill under the same tax ID. And while they're part of their group is called Comprehensive Urology, but we're all technically MHP employees. I'm with PrecisionIR, but my paycheck comes from Michigan Healthcare Professionals. So we're part of the same organization.
Gotcha. Okay, so they are like slightly financially incentivized, not financially incentivized, but not disincentivized to send you patients, right?
Yes,
okay.
Absolutely.
Yeah. That makes a big difference, yeah.
Yeah, it is. I mean, obviously, we want to do the best for patients, but yes, there are other factors involved as well.
So they approached you. That's also the interesting thing I think in this situation. Tell me a little bit kind of how that went.
Well, the urologist over there, I started a renal mass clinic back at the hospital when we were there with some of these urologists. And so my plan was, when I came to the outpatient setting, to keep seeing their renal mass patients and do ablations. And we do a fair number of kidney ablations and things like that. So already had a relationship with them about it. And, just in discussions, it came up, the prostate artery embolization, and they were interested in it. And I, of course, as a business owner, having to pay my staff and keep the lights on, I was very interested in it as well. And the discussions just sort of evolved from there, and they started sending patients. And, as I said, it was kind of slower at start. They wanted to see how how it worked and how their patients tolerated it. And then, as they started to see some really good results, then they started a lot of the rest of the group got involved. There's 50 urologists in the group. So
big group. Yeah.
Yeah, it's a very big group. So.
Oh, that's really neat. Did you feel like the younger guys in the group were more willing to send folks early on, or did you get buy-in from some of the older urologists as well?
The president of the group is actually the one who probably sends me the most patients, and he's an older guy. I mean, he's probably, I guess, speaking of myself now, he's around my age and maybe just a little bit senior to me. But I think both aspects, the younger guys in the group and gals in the group, and then the older ones, I think everyone sort of is sort of getting on board with it, and they're really getting more interested in it. One of the urologists in the group is predominantly practices in Detroit at the Detroit Medical Center, and he got very involved, and he's the program director for the residency down there. So he's invited me to give talks down at DMC to his residents and just really sort of spread the knowledge about the procedure and, the benefits that it offers.
So when a urologist sees a patient and evaluates them for any kind of procedure for their prostate or BPH, when do they tend to send people for PAE rather than do a TURP or a minimally invasive procedure on their end?
So great question. I think they always talk about, obviously, the transurethral treatment options and everything like that, but our patients are becoming more and more educated, and they know about this procedure, and they start to ask about it a lot more, and they always offer it. I think that in the right candidates, obviously, in larger glands and patients that may not otherwise be great surgical candidates for them to do a TURP on or some other transurethral procedure, they offer the PAE procedure.
It'd be really interesting to see kind of in the urology subset how many end up choosing PAE versus a different type of minimally invasive prostate procedure.
Absolutely.
Yeah.
I wonder what their numbers are, just because of, the number of patients that we're seeing. Obviously, it's a very, very common problem in our male population. And so, I don't know. It's just interesting to find out.
It's just going to be growing. Talking about prostate embolization, just to wrap up this portion of the segment, do you use cone beam CT?
I do.
Awesome.
I do. So
okay.
as when I originally came out here with the intent of doing radioembolization, I thought it was absolutely imperative that I have a cone beam CT. And, I obviously financially invested in having that. And we have a Siemens unit, and I certainly take advantage of it. If it's there, why not use it? And it's not much radiation, and it helps you feel very comfortable about what you're doing. Feel a lot
absolutely.
Better.
Yeah, I think I have a cone beam in mine as well, and I think I kind of lean on it more than not. Like if I'm not sure about something, I'll do a cone beam, more often than if I didn't have one. Definitely.
Yeah, I would say early on in my experience with PAE, it was always doing a cone beam in the internal iliac. Now it's just I get into the prostate artery and then I do a cone beam just before I start embolizing.
Yeah. And then if we talk about workup for these patients, do they kind of come nice and packaged for you from the urologist, and then you pretty much do the procedure and send them back?
Absolutely, yes. That is actually one of the very big benefits. I mean, we see, a lot of the patients I just do telephone consults with because they are coming from the urologist, and they are a very good candidate, I would say. So yeah, the patients do kind of come pretty well ready for the procedure. I've sort of had back and forth with the urologist and just said, hey, it would be great if we had a prostate size. They get prostate ultrasounds on almost all of their patients. If they don't have a prostate ultrasound, if they had a CT or something, we can use that. But most of the time, the urologists are getting prostate ultrasound. They are getting blood work that we need. I mean, for me, it's just kidney function is what I am concerned about. And other than that, they're teed up, ready to go.
Wow. Okay. So no CTAs, pretty much can do it based off prostate size. Do you have a lower limit cutoff that you use for prostates?
I 40 to 50, I have a talk with the urologist and the patient. Below 40, I don't do. Anything above 50, I'm pretty comfortable with.
Cool. Is there an upper limit size for you where you're okay, what's the biggest one you've done then?
375 grams.
Oh, dang, dude. That's like a uterus.
I know. It was a couple of, vials of particles too. So
oh, yeah.
Yeah.
Oh, man. Okay, so there's some OBLs in the country that have some pretty advanced stuff for selection. Do you have a go-to for what you like to use to select?
As far as catheters?
Yeah.
Or
kind of just walk me through I guess I would want to say, since you're doing so many of these, walk me through how you do the procedure.
Okay, so procedure, 6 French sheath in the femoral artery. I do all of them through femoral approach.
Okay, cool.
I was, Dr. Lippman said he does all his UFEs by the femoral approach, and he said stroke risk. You can't, even though it's incredibly low, it's not zero from the radial. And I kind of took that to heart a little bit, and then most comfortable operating from the femoral approach. So I figured it's best for me, it's best for my patient as well. So femoral access, 6 French sheath, usually C2 to get up and over, get into the internal iliac. If the gland is 50 grams, I'm using a 2.4. I use the Prograde, and I use a Meister, Asahi.
The 016 Meister. Yeah.
Yeah.
That's been a great wire for prostates, you know?
It's a great wire. Absolutely.
Yeah.
I started using with the Fathom, but I felt like the Meister worked a little bit better, and it's also cheaper, so
Yeah.
even better.
Yeah. You have a 2.4 prograde. Now you said if that's 50 or over, do you use a straight or a angled prograde?
Good question, because I thought, in my, I guess, ignorance, I thought they only had the angled 2.4, and that was like what I did my first 100 or so on, and my rep was like, we have a straight one that's also cheaper. I'm like, oh, that's interesting. So let's give that a shot. And so, now I use the 2.4 straight. And, we also have J-tipped, the hockey stick, and 2.0 catheter as well. My partner still uses the 2.0. He's more comfortable with that. I'd say the first 50 or so I did with the 2.0 size as well. So that usually gets the job done. If not, we could try other wires. I'll go to if the Meister doesn't work, I'll try the Chikai, the 014 Asahi Chikai wire. And then on one case, I've actually broken down and gotten a Swift Ninja catheter out. And
yeah, you have it like behind glass, and it's like if absolutely emergency kind of thing.
Absolutely. Like, don't tell my partner that it's there. So
but
I know
Swift,
that
the Ninja got you in, huh?
It did. It got the job done. It was a very helpful, but it's a lot more expensive, right? And obviously it's part of the thought process now when you're responsible for all of that. You have to take everything into consideration, and
for sure. Yeah. Okay. So then you got in. Do you give nitro? Do you give verapamil? What do you do?
We give lots of nitro. Absolutely, lots of nitro. I don't really give verapamil. I can't think of a time when I've given verapamil except if I did a radial approach. But lots of nitro. I give nitro right when I get into the prostate artery, and then plus or minus depending on their blood pressure, I'll give it again 200 micrograms at a time just to get a little bit more distal before we start treating.
Okay. And then you start embolizing, and then you give more after like a vial, or
no. I'm sorry, I might have spoken correctly there. So I give it right when I get into the prostate artery. We take our cone beam CT at that point. If I feel like I need to get more distal, I'll give more, and then I embolize. So once I start embolize, I usually don't give any more nitro.
Gotcha. How often are you having to coil off accessory branches?
I would say 20 to 30% of the time, I think is a fair number. I guess I haven't really found out what the exact numbers are, but I think 20 to 30%. They really tolerate, if I could just get past the branches going to the bladder or the rectum, I feel pretty comfortable. Obviously, any branches going to the penis, I'm very, very leery of, and need be, I just won't even treat if I can't occlude it.
Yeah. I've had actually some operators who've been doing really high volumes, such as yourself, say that if you get 300 to 500 beads in those, that it's not a big deal. But I haven't really been trusting myself enough to do that. You know what I mean? Just because it's early on in the process too.
Sure. I use, I didn't mention it before, but I use 100 to 300s for embo. And, I used to, when I first started, I was using 300, 500 embo spheres. And I just find that, clinically, the results we get with the 1 to 300, I think it's a little bit better. Again, I don't have a number to tell you that it is definitely better, but I feel it is better. And I've varied from the, I've used the hydropearls, the embozines, the embospheres. I'm most comfortable with the embospheres. The hydropearls I just can't get because my friends down the street have bought all of them.
Oh,
for the next 10 years, I think. Even though I'm probably one of Terumo's biggest customers in the state, I can't even sniff at those.
Wow. Yeah.
Yeah.
They said they weren't taking on any new accounts because they were basically saturated. Man, pretty wild.
Yeah. It was very interesting because last year I could get hydropearls, and then, this year it's just, no, sorry. So, all right.
Well, you're not the only one, my friend.
Okay. Yeah.
Are you part of a GPO or anything that does your purchasing, or is it just you?
So I joined this company called Margin, based in Ohio.
Okay.
With Chaz Sanders.
Sure.
And he's helped out a lot with the inventory management. I think it's good price. It's very easy to keep track of our spending with that platform. And I'm sure if I just, like if I didn't have that and I took the time to make a spreadsheet, I could probably keep track of it, but he does make it very, very easy. And the ordering is very, very easy because we could do it all at one spot. And then, their company gets, all the orders out to the respective vendors and everything comes to us.
That's neat. Yeah. And I'm really interested to see kind of what happens with our supplies over the next year or the next 2 months with all the supply chain stuff and the tariffs. I'm super stressed out about it, actually.
That's very interesting. You mentioned that. My technologist, who's my inventory manager, she just ordered literally before this episode. I think I took in like 20 boxes of case packs that were just sitting outside my office door. And I'm like, okay. I
You're
guess
stockpiling eggs, man. You're stockpiling toilet paper.
That's
case
right.
packs.
The case packs. You're going to be in the Meijer parking lot selling them. Absolutely. But it'll be very interesting to see because, Terumo is what all the products are coming from Japan. Some of our other companies are coming from Europe. I mean, who knows? Right now, I haven't really seen a difference in the price. I don't know if you've had that experience, but
I'm not intimately involved enough in that stuff right now by choice because it would take over my life, I think.
Yeah, that's another thing, that being an independent operator, you start to become intimately aware of the costs of things. Like we spend over $80,000 a month on medical supplies that just go in the garbage after we use them. It's amazing.
Isn't it wild? Yeah. And then keeping your PAR levels kind of so that if you don't use something for 6 months, it doesn't expire, and then you're throwing away really expensive devices. Yeah,
like the Swift Ninja.
Yep. Super complicated.
Yeah.
We've gone a little bit off track, but back to the PAEs. So after you do the PAE, closure device, do you use a closure device?
I do. I use the AngioSeal.
Okay, cool, man.
I never used it in the hospital, and came to the outpatient center, and the Terumo was like, you just got to try this, and I don't want to use anything else now.
Yeah. And then how long do you keep them in the lab after you're done?
So we watch them for about an hour. If everything looks good, obviously we get them up, moving them around a little bit. And then if they're okay at that point, we send them home.
Cool. Have you ever had any issues with like acute urinary retention after a PAE?
We had, I think, one case that, the patient needed to be straight cats one time and they were okay. But other than that, knock on wood, they've been, have not had that.
That's great. And then they do their follow-up with you or with the urology group?
So both. I do a 6-week follow-up with them, and then they usually see their urologist about 2 to 3 months after the procedure.
Cool.
And so, we call them the day after, see how they're doing, and then usually it's a phone visit is basically what it's come down to. It's just easier for them, and they prefer that. Obviously, we're, mostly concerned about their symptoms, and, if we can get a good sense of that, then I feel it's pretty adequate.
Do you send them home on any medications?
We do. And, it's a constantly sort of evolving thing. But, most patients, if they're not diabetic, we'll send them home on steroids, Motrin, and antibiotic. We either use Bactrim or we use Cipro, and then Pyridium to help.
And then when you're talking about outcomes for these patients, what do you kind of quote as expected results and when they should see results by?
One of the main things I say in my consultation is that I'm not a magician. Can't make it like you're 25 again. Hopefully we can get some improvement. And I think it's very important to set the expectations. And I'm very clear with them that, this has been shown to be 85% effective in helping patients with your types of symptoms. So, play the numbers. If I treat 100 patients, 15 of those aren't going to get the results they want. And so we just have a clear discussion about that, what they can expect. I usually tell them they're not going to like me for a few days after the procedure because it's going to be very uncomfortable to urinate, and they won't see symptom improvement for about 4 weeks. And in some patients it can take longer, but I'd say the majority of my patients are seeing some improvement by about 4 weeks.
Okay.
And so that's why I follow up with them at 6 weeks. Gives them a little bit extra time to get over that post-procedure period and the discomfort, and then starting to see some results.
Awesome. And the patients who maybe haven't had the outcomes that you've wanted or expected, anything that you felt like you could have done differently?
Certainly on some cases, I would say there are things you could do differently. I mean, if they're not having before I meet with them and follow up, I look over their procedure. I want to, get a sense for myself, like how well did we do on the procedure? How well did we embolize the prostate? And if, sometimes I can't get into one side. And so it's a unilateral, embolization. And so I'm entering that discussion thinking they're not going to be as happy. And after that, I mean, if it was a case where we could only get into one side and I thought that, maybe using different equipment or a different approach would be a benefit, I offer a retreatment. Other times, I just, some patients, diabetics, bad atherosclerotic disease, which we've all seen, they're internal iliac occluded. Obviously, there's not really, much from the endovascular side that we can offer, but they could still certainly get transurethral procedures. So all is not lost for them.
Yeah. Yeah. Kind of like setting expectations, like you said.
Yeah.
Super important. Okay. So anything else kind of you want our audience to know from your extensive series of prostate embolizations that you think might help somebody starting this practice?
I think that it's a learning curve. Getting, the first 30, 40 cases under your belt is very important before you start to get a little bit more comfortable. I think that even after that, though, it's a humbling procedure sometimes. You feel like, oh, I'm getting the hang of this now. And then next day you're like, well, I feel like I've never done this before. So I think patients having the, knowing that there are other options if you can't do the procedure as well. Like you're not abandoning the patient if you don't try for, 4 hours to try to do a prostate embolization. I'll have half my staff quit, but if I take that long.
Yeah. Yeah. So it sounds like you do like 3 or 4 a day now, right? Basically.
Yep.
Wow.
Yeah. So it's been fun, like trying to figure out how to work with, my techs and my nurses. I mean, getting everybody on board, try not to place blame on like not getting patients on the table in time. I mean, it's, we like to do our first case at 7:30. So that means that I want to be able to consent the patient at 7:15. And I would say that, 80% of the time we're starting the procedure by 7:45. So it's, within that realm, but I mean, it's a team effort and, everybody buys into it and got to keep everybody happy, I guess.
Yeah. Gosh. Yeah. Yeah. That's the biggest thing too, is when you're working in a OBL, you have a really small staff, right? And you see each other every single day. It's not like when you're in the hospital, you're rotating around.
Yep.
Somebody else is in charge of everybody. It's like, it's you.
I've been very, very blessed to have great staff. Knock on wood again, I haven't dealt with employee turnover. I probably pay them a little bit better than, the average, which I'm happy to do just because I think, obviously it's a team approach and I can't do it by myself. And having people there that are good at what they do is just priceless.
Absolutely. Cool. Well, let's talk about some other procedures you're trying to grow in your lab. I mean, you mentioned UFIs. I can definitely think of some barriers to growing that, but what do you think is the deal?
Well, I think the main deal is that our colleagues in OBGYN just don't mention it as a treatment option for symptomatic fibroids. And I think that's a little bit of a disservice. I mean, I looking at PAE as well, I always tell them there's other options that they could use for treatment. So for fibroid embolization, the patients that I see are generally patients that are just told they need a hysterectomy and they don't want it. And so then they start Googling and, half the time they'll tell me about, Dr. Lippman in Atlanta.
Yeah.
Okay. Yeah. We could do that here too. But trying to, I think for the UFIs, we need to get direct to the patient. Marketing has to be targeted right at the patient level. Talking to family practice docs as well, I think is very, very important because they do have that in their practice as well. And just keeping going with the marketing. I can't emphasize that enough. It's so hard to, when you're in the hospital, you're getting a paycheck whether or not you see the patient or not. And your drive to get the patient in the door is maybe not as intense as it is in the outpatient side. But if you have any pearls of wisdom for me to get more UFI patients in the door, I'm happy to listen.
Man. Well, okay. So here I've come up with a theory, and I think this is why I'm getting a lot more referrals for PAE and GAE than UFIs. Okay. So PAE and GAE, that affects older people, right? Older people are usually retired. They have lots of time on their hand to worry about the stuff that's going wrong with them. And they are oftentimes at least the ones I get are fairly medically literate. And so they want the newest research online and they want the newest, fanciest things. UFI patients are usually 30 to 40-year-old women who are managing 8 other situations with themselves and their families. They could be bleeding to the point of anemia and, requiring blood transfusions, and it like won't be on their radar that they need to get this managed. And I think that that little bias between the patient populations really hinders our ability to manage UFI patients effectively. Because they'll go to their doctor. The doctor will be like, okay, just do this. And they're like, okay, yeah, it'll take care of the problem 100%. I'm in. Let's just do that. I can get on with my life, And I think it's a huge disservice, but I think that's just kind of like the two different patient populations we see for those OBL procedures.
Yeah, I think that's a really good perspective. I think it's interesting. I hadn't thought about it that way, but it's very true. I mean, I think that you're right there. Maybe there are a lot of other things going on, and this is just another thing that they're like, all right, let's just get a Band-Aid on this right now and take care of it. And yeah, that's a good point.
Yeah, and I think it's a men versus women thing too. I think we always joke that like the worst PICC line patient is like the 25-year-old guy that comes in with a million tattoos.
Whatever Dr. Lippman does, he's got the secret sauce, and
yeah.
Has really, built a strong, amazing practice. And just to listen to him and how he does it is just, hey, whatever I can learn, that'd be great.
Oh, 100%.
Yeah. And the thing is it's very interesting because you get these patients and they're so happy after the procedure.
Yeah.
Right? It's life-changing. And like, I had a patient, her hemoglobin, she'd go to the hospital, it's under 5. And they're just saying she needs a hysterectomy and she keeps refusing, and then found me on Google. And it's just, why did it get to that point? Why does it need to get to that point? And then you'd think that, if you had these patients that had such good outcomes, they would scream it from the hilltops, right?
But that's the thing. Like then that traumatic part of their life is over. They don't want to revisit it.
They don't want to talk about it anymore.
And like the stigma around having fibroids, around like dysfunctional uterine bleeding, like they don't want to really be associated with that anymore. So you changed their life. They're thankful for that, but they're not. I don't know. I feel like they're not like super eager to scream it from the rooftops like you think they would.
Right.
Totally.
Well, I think we see that a lot more with prostate embolization. As I say the biggest compliment I could get from my patients is they refer someone. And, they said, I am telling every person I see that has these symptoms to get this done. And it's just, obviously it's so common for them. It's just, they probably, it's like a new normal, just having to go to the bathroom every, 15 minutes. And so they're comfortable talking about it, I guess.
Have you kind of gotten into the genicular artery embolization space?
So, it was interesting. Before this episode, I was looking at some of my numbers, and we've done, I think, a dozen GAEs. So not as many as I would like, and we've tried different approaches. Initially I would come up and over to do an embolization, and now the last 4 or 5 patients I've done pedal approach, which I think is a lot easier and quicker, but haven't really, again, had the, sort of adoption of it or an increase in patients. So,
that's
but I just,
one.
if it's not there, then, I have other things that I'm doing.
Yeah. You seem busy enough, my friend.
Yeah. And it's, we used to, when we first opened in November of 2022, I think I did 4 thyroid biopsies, and I was like, I'm never doing these again. Like we would do biopsies and ports. We did over like 1,000 ports. And if it's, I didn't take my first paycheck until 2 months ago, actually. So it was 2+ years before I could even pay myself. And, you do what keeps you busy, keeps the lights on, and, hopefully, it works.
Gosh, yeah. Such a good point. Like people think we're like just rolling in money and with OBLs. It's not like that, right? The margins are super thin. Like one thing can tip you over, and yeah, just the I would love to know what the average time to profitability is for a given OBL. I've heard quotes between 9 months to like 2.5 years, like you said. And like I think the expectations that you just show up and you're doing 3 embos a day, 5 days a week, and just like making tons of money. It's not realistic, right?
It is not at all.
Yeah.
And that's very true. I think you had Dr. Jerry on recently, and he talked a little bit about that. And, the other thing is too, it's like biopsies was kind of like one of the predominant things I did initially. The only times I've had to call, I mean, knock on wood again, had to call EMS 4 times in my office, and they've all been biopsies.
Really?
Yeah, and I find those to be some of the most challenging cases. And, you almost feel bad about saying no to those, but it's going to take up half your day, and you're underwater before the procedure started.
Right.
And then on top of that, then they have a complication that you can't treat in your office. And, in the hospital, when I did them, I felt pretty if I had bleeding, all right, we'll take them to angio and try to take care of that. But here, I mean, I guess technically I could take them to angio, but people would, really not really like that. I don't think. I think it's more appropriate to get them to a hospital. But it's, some of the things that we like to offer for our referring doctors and want to help them out, we just simply can't based on the physician fee schedule and other barriers.
So then, you have this group of hospital people who are well, everything should just be done in the hospital because it's the safest place to do stuff. And I think I have a counter argument to that, but I'd love to hear your counter argument.
Well, I think that, there's a place for things in the hospital, but I think that people that go to the hospital get sick. And but at the same sense, I think that hospitals are better equipped to handle some of the biopsies and other things like that. I don't think that they can do the volume of embolization procedures that an office can do.
Right.
They can't do it.
The turnover, yeah.
Yeah. It's impossible. And for whatever reason, I mean, obviously there's political factors, there's, staffing and everything like that. But I think some things that, embolization procedures should be done in the outpatient. I think some of the vascular work, obviously, that's done in the outpatient is definitely more appropriate to be done there. I might have gone off topic a little bit there. Sorry.
That sounds good. Well, cool. I've learned some tips and tricks. I'm excited to see your practice grow. You plan to kind of be a solo guy, more or less solo guy for the rest of your career, or do you have dreams of expansion?
I would say I have dreams of expansion. I guess I don't know when that point is. It's interesting. When I started, I actually offered other doctors part of the company, and they both said no initially when the time came to sign on the dotted line. And looking back at it, I'm very happy they said no, because obviously, we had a vote and it's what I wanted and that's it. And, if you have someone else, it can work, but there's you have to have compromise and things like that. And I think in the future, if I were to expand, possibly taking on a partner would be good. But right now, I think just having the last say is the way to go about it.
Isn't it nice to not have anyone tell you what to do? I mean, it's pretty fun.
It is. It's very, very fun. And I think running a business is super fun as well. I have, as a doctor, we're looked at as very well-to-do people, but in my group of friends, I'm kind of the pauper in my group, and, they're all business owners. And, I think a lot of them sort of encouraged me to make this leap. As I said, you need to do this on your own. And, my best friend from growing up actually was very wildly successful and was able to give me some money to start. And so that was, I was very, very fortunate in that. But he's just look at it now. Don't you love it?
Yeah. Oh, I love that you have a friend like that. That's so great.
Yeah.
How lucky are you? Oh, man. Okay. Well, Dr. Vartanian, thanks so much for talking to me. I wish you the best in your practice. And
thank you, Ali. It's very nice to meet you and nice to speak with you. And you guys got a great show. And thanks for having me on. I appreciate it.
Thank you so much for listening. If you haven't already, make sure to subscribe and follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, or Blue Sky. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck, Sabine Dawn, Michael Barraza,
and Ali Baheti.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe Legrizio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again. See you next time.